Welcome to Communication Skills Lecture Part 2. If you haven't already watched Part 1, please stop this recording and find Communication Skills Lecture Part 1. I'm Dr. Catherine Miles and it's my pleasure to teach you this morning. So, we looked before about how it's important to do something really skillfully, and it takes time and practice to be able to produce something as beautiful as this cake. We know that we want knowledge and skills and practice, and the same is true for medical consultations. We looked last time in the Part 1 lecture at some of the communication skills that we can use in consultations. We talked about rapport and about screening, active listening, using open to closed questions and clarification. So take a look at this room. Remember, we talked about the different consultation models that we could have, whether we are following a patient-centered consultation model or more of a medical model, more of a doctor-centered model. And at the beginning of the consultation, we talked about those really important golden minutes of introducing ourselves well, developing rapport with the patient, having a good first open question, and listening actively. And we want to be attentive to what the patient's saying, encouraging them, yes, to keep talking, not to interrupt them, and to not make them answer a question again that they've already answered. We also talked about presenting complaints and how it's important to use the skill of screening, which is asking if there's anything else to check that there's no symptoms have been missed. And also then setting the agenda and deciding what exactly we're going to focus on that day for that consultation. And we also looked, as we find out more of the story, the history of the presenting complaints, we can use other skills such as an open to closed question cone, and also clarification, making sure that we really understand what the patient is meaning by what they're saying. So let us move on today to look at some more communication skills. These include picking up cues, empathy, summarizing, and signposting. So picking up cues. A cue is something that is said or done that is a signal to the doctor to show what the patient is thinking or how they're feeling. And cues can be both verbal and non-verbal. So for example, a verbal cue might be the patient saying, "Oh, it's been a bit difficult lately at home. I've been getting lots more pains lately." And the doctor will realise, here's the patient saying this is a bit more difficult. He's saying this is getting hard, it's affecting his life. So you can follow it up and say, "Oh, what is it about the pains that's been making it more difficult for you today or at home?" Other cues can be by our body language, by our hand movements, our speech. Maybe a patient is sitting there looking down, being very quiet, being very sad and feeling depressed. Or maybe they're talking very quickly and they're very anxious and very nervous. So we want to pick up these cues of what patients are showing us as to whether this is affecting and how it's affecting their lives. So we can have both verbal and non-verbal cues. And the way of picking up these cues is to then maybe repeat it back to the patient. If they say, "Oh, I've been very upset about this." Upset? And just as a question to let them talk more. Or maybe you can check out verbal cues by saying, "Oh, you were worried that the pain might be something serious. Can you tell me more?" Or even if you pick up a non-verbal cue, you can say something like, "I sense that you're not feeling very happy about the explanations you've received in the past. Is that right? Can you tell me more?" One thing you really need to do to pick up cues, these signals from the patient, is actually to be looking at them. Okay, if you're too busy looking at a computer screen writing notes, you won't be able to pick up especially the non-verbal cues. So then we move on to the patient's perspective. We've talked about this in the structure of the consultation. And remember that different patients experience things differently. We can ask about their ideas, concerns, expectations, ICE, or another way of remembering this is FIFE, F-I-F-E, feelings, ideas, function, and expectations. So very similar. The addition is the function as to how it's actually affecting their life. And why is it important for us to know the patient's perspective? Well, understanding the patient in front of you will really help you to know why are they feeling how they're feeling. And when you come to explain to them the diagnosis, having that background information of what the patient expects it to be will really help you. Because if the patient comes in thinking, oh, this is something very simple, and you have to end up saying to them, we need to do some tests, we think this might be something really serious, such as cancer. That's a big difference between the patient's expectations and where the information is at. But if a patient comes in and they say, oh, doctor, I've had this lump in my breast, I'm really worried it might be breast cancer. My mother had breast cancer at a similar age to me. You know, already they've got expectations it might be breast cancer. So then if you think, yes, actually, from the history and examination, you think it might be, it's much easier to give that explanation and diagnosis. So that's one of the reasons why it's so important. And as we said, different patients will experience things differently. So in terms of ideas, what are some of the ways we can find out somebody's ideas? Well, you can ask them, tell me what you think is causing it. What do you think is happening? Do you have any ideas yourself? Do you have any clues, any theories? Maybe you've given this some thought. Can you tell me what you're thinking about it? What about their concerns? Obviously, you can ask, are you worried about anything? Is there anything you are concerned that it might be? Is there anything specific you are concerned about? What is the worst thing that you think it might be? What have other people said to you that they're worried this might be? And then in terms of expectations, you can ask, what were you hoping we might be able to do for this today? What do you think might be the plan of action? How can I best help you with this? You know, what did you think would happen in terms of tests or in terms of the next stages? What do you think will be the next steps today? And it's important, as we've said, to really understand the patient and to help you when you come to explain to them what you think the diagnosis is and what the treatment plan may be. It's also important to show the skill of empathy, particularly when patients say, I'm worried about this or I'm concerned about this. So what is empathy? Well, empathy is listening to the patient and showing that you understand what they are experiencing or feeling. Now, obviously, you can't fully know how they feel, but it's like putting yourself in their place to say, I understand this is difficult for you. I understand you're worried about that. We have a saying in English, putting yourself in someone else's shoes. You're experiencing it as if you were that person. And empathy helps to build that relationship with the patient. So you want to say, I understand you're feeling worried, or I'm sorry to hear that your mother died or your mother passed away. It must be very difficult for you being in pain and looking after your children. So it shows that you as the doctor really understand where the patient is at, how they are feeling, what are they finding difficult. Again, empathy can be shown at any point in the consultation, but particularly at the patient's perspective, or maybe in the family history. If the patient says, oh, my mother and father have passed away, have died, and you can say, I'm sorry to hear that. Another skill that you can use is summarizing. Now you might think, why have I got a picture of a parrot? Well, giving a summary can sometimes be like parroting, like a parrot repeats back to you what you've said. And the same is true for a summary. So a summary is not containing advice or your opinion. It's repeating back, even using the same words that the patient has said, that helps them to keep ownership and shows that you have been listening to them. So when you summarize, use the patient's own words. You don't have to say everything that they've said, but the key points to show you that you've been listening. And it allows them also an opportunity to correct you if you actually have heard something wrong. Another benefit of summarizing is it gives you time to pause and to think about what has been said and where you want to go next. It gives you time to think about what you're going to say next or what you're going to ask next. So for example, a summary would be maybe after you've found out the story of their illness, the history of the presenting complaints, you could say, oh, you said you had pain in your chest, there is a dull ache, it started 2 hours ago, and now it's also painful in your jaw and your left arm. Or you could give a summary. For example, you feel sick for the past 2 days and you vomited once this morning after eating breakfast, but you've had no pain. So that would be a quick little summary to show that you've listened to the patient, and then you can move on. Another skill that can be very helpful is signposting. Now, signposting is pointing out the direction that the consultation will go in. So it's a useful skill for providing structure to the consultation. It's really saying to the patient, this is what will be talked about when. And it helps the patient to know, okay, I will talk about this at this stage. And so it actually helps to make consultations more effective and efficient. So it can be used as a tool for summarizing. So you can say, can I just check that I've understood you? So it's summarizing that it's signposting that you're about to give a summary. So it's telling the patient, can I just check that I've understood you? Let me know if I've missed anything, and then you give your summary. It can be used when you move from more open to closed questions. So you could say, can I just start by asking you a few more questions about the pain that would help me to understand this? And you can also use it to move from one section of the consultation to another. So for example, if you've finished the collecting information about their problems at the moment, you could say, thank you so much, that's really helpful to hear about the problems now. Can I just ask you some questions about your health in the past and your family's health? So that's signposting that you're moving on now to the past medical and surgical history and family history. So these are the skills that we've learned about, the different communication skills that you can use in the consultation that have been proved to help consultations to be more effective and efficient, to help you to really understand your patient and get the correct diagnosis. Now, some of these skills need to be used at certain points. For example, screening needs to be done at the start. Is there anything else you want to ask at the beginning of the consultation about, are there any other symptoms? At the end of the consultation, you want to be finishing. You don't want new symptoms at that point. For example, setting the agenda. That happens at the start of the consultation. You want to make sure that you have decided, okay, we're going to talk about these things today. But for a lot of the other skills, actually, it can be used at any point in the consultation. And that's part of practicing and learning how to use these, is working out when it works for this person in front of you. When do you want to use these skills? For example, please do not give a summary after every single thing that the patient says. So you can actually use these skills too much and it becomes false and not natural. So maybe you want to give a little summary after the history of the presenting complaints and a little summary at the end. But you don't need to say to the patient, so your name is Mr. Mohammed and you are 45 years old and you've come today with chest pain that moves to your shoulder and it's 10 out of 10 severity and you have had no operations in the past and no illnesses in the past and all your family is well and you do not smoke and you do not drink alcohol and you do not take any medicines. Okay, you don't need to say that as a summary to the patient. That is a summary that you would give maybe to another colleague. So if you're giving a summary to a colleague about a patient's case, yes, then you would say, I saw Mr. Mohammed, he's age 45. These are the key points, and the key points that are negative. But when we talk about a summary to the patient, it's really to show that you've been listening and allow the patient to correct you. So much more like, oh, so thank you so much for telling me about your pain. You said you've had a central chest pain that comes on over the past few months, especially when you're walking uphill, and it's really starting to worry you. You think it may be from your heart. That's a good summary. Okay, so do get a balance, do practice these skills, do use them in your sessions. These are some of the references from today, and as I said, it takes good knowledge, good ingredients, time, practice and skill to actually making a beautiful cake, or in our case, to make a good consultation with our patients. We want you to learn these communication skills to become really good, competent doctors. Thank you very much.